fluid therapy and sepsis. Okay, I don't know how questions can be asked in this. I have done this class in the regular group as well. Okay, what I'm anticipating is previously they had asked about rose concept. Okay, so that is one place where I thought they might ask. Then they can ask you critically analyze about fluid therapy in sepsis itself. Okay, so therein how will you approach this answer is what I want you to go through in this particular question. So, what is the aim in fluid therapy in sepsis? It is targeted intravascular administration of fluids, or it can also be removal of fluid. It is majorly aimed at restoration of tissue perfusion, oxygen delivery, and organ function, wherein you are looking at avoiding a catastrophic event like volume overload. Okay, so that is the main aim of fluid therapy in sepsis. Okay, so what is the pathophysiology? We all think sepsis is a state of hypovolemia. Okay, so the main important thing is sepsis is a state of relative hypovolemia initially. Okay, only when we do not treat that appropriately that it goes to a spiral of a vicious cycle of shock. Okay, so that is what we need to offset. It is not necessary that all septic patients are hypovolemic. No, probably we might have to assess their status and then take a call. Okay, so the pathophysiology usually would be like initially there will be a state of vasodilation caused because of inflammatory markers and release of nitric oxide. Majorly because of inflammatory markers, there will be endothelial damage, there will be capillary leak, and extravasation of fluid into the interstitial space. Okay, and because there is extravasation of fluid into the interstitial space, there will be decreased intravascular volume that leads to relative hypovolemia initially, and because of decreased intravascular volume there will be microcirculatory dysfunction leading to organ impairments or there'll be organ damage. Okay, so this is usually what happens in sepsis. Okay, so sepsis shock pathology, you know, it's a toxin driven systemic inflammation leading to endothelial activation, vasodilation, glycocalyx degradation. Okay, and thereby causing relative or absolute intravascular hypovolemia. Okay, so this causes decreased preload, cardiac output, and microcirculatory flow, which has a varied effects on the total body water. Okay, so if at all we do an overzealous treatment at this particular stage, probably it can lead to detrimental effects of fluid therapy like interstitial edema, worsening oxygen saturation, impaired organ function, okay, compartment syndrome, etc. Okay, so these are the issues which we face with septic shock or sepsis fluid management. Okay, so remember that fluid is both a therapy and a potential toxin if it is misused. So what is the goal of fluid therapy in sepsis? It's to restore adequate preload and cardiac output. It is to improve tissue perfusion and oxygen delivery. It is to correct metabolic acidosis and lactate clearance and to support organ function, especially when there is septic shock. Okay. Always remember fluid in sepsis is not only with patients with septic shock. Okay. Most of the times patient will come in just with sepsis. There will not be any shock associated. Shock develops over a period of time. Okay. That is what I want you to understand. So what do we do initially? So imagine that this patient has come to you and we are giving fluids. How do we do that? We need to assess the patient. So if at all a question is asked about how do we manage fluid therapy, we have to start with firstly treat a fluid like a drug. Okay, and then you can tell that there is state of relative hypovolemia initially, then it can progress into septic shock. If you write these 2 points as an introduction to your paper, it's more than enough. Then you write what is the goals of fluid therapy, that is restoration, improvement, correction, and support. Okay, so if you remember this, that should be majorly about your initial part of your answer. Then write about assessment of fluid status. Okay, and then when we have to start fluids. Okay, how do we do the assessment? Firstly, we see for the windows of perfusion. Okay, like your mental status, capillary refill, peripheral perfusion, urine output. Okay, and your vitals like heart rate and blood pressure. Then we look at the blood pressure targets, whether the map is more than 65 mm of Hg, that is your initial goal, and whether that map is having an adequate urine output of more than 0.5 ml per kg or not. And at this particular time, if at all there is hypovolemia, based on your dynamic tests of fluid responsiveness, probably you can give fluid therapy to this patient. Okay, so this is a stepwise approach to how we assess volume status in a patient with sepsis or sepsis with septic shock. Okay, so start with clinical signs, define your targets, use dynamic tests of fluid responsiveness, and write about bedside adjunctive tools like your ultrasound, okay, or your echo. Okay, so this is what you need to write about assessment of volume status and need for fluids in patients for sepsis with septic shock or fluid therapy in sepsis. Coming to fluid initial resuscitation, we all know SSG 2021, they say 30 ml per kg within the first 3 hours. Remember, it's not a rigid rule. Why is it not a rigid rule? That is one of the major reasons why it got actually a downgraded recommendation. Okay, I will talk to you about it later on. By saying that, I'm not telling you not to give 30 ml. What I'm trying to tell is start the patient on an initial 30 ml per kg, but please always go ahead and do an hourly assessment of fluid responsiveness. If you feel that your map target has been achieved, the lactate has been cleared, or any other hemodynamic abnormality has been corrected, probably you can stop or reduce the fluids at that particular time. Okay, it need not be that you have to give all the 30 ml per kg in the first 3 hours. Okay, that is what we need to understand. That is the reason it is not a rigid rule. Okay, why is it so? I'll tell you later. Okay, that is because there was no mortality benefit which was seen. Okay, after the EGDT trial, EGDT trial was the one thing which they all focused on giving 30 ml per kg. Okay, following that, Arise, Process, and Promise went ahead, used the same protocol to see, and what they found out was there is no difference in mortality in both the groups. Okay, wherein they use a lesser fluid volume as compared to 30 ml per kg. Okay, so that is one way they came to an understanding that there need not be a rigid protocol telling that all patients with sepsis require 30 ml per kg in first 3 hours. So that is one of the reasons this recommendation was downgraded in the 2021 update of SSG guidelines as compared to 2016 guidelines. Okay. So once if you have understood 30 ml per kg should be given in the first 3 hours after assessment of fluid responsiveness in a patient with sepsis, then what do we do? Okay, so this is what we have done till now, right? So we have seen what are the issues, we have examined the patient, we have understood that this patient is having fluid deficit, gone ahead and given, and if the patient is responding, there is adequacy of restoration of organ perfusion, etc. Well and good. If it is inadequate, probably we need to choose vasoactive agents. What are the resuscitation targets we are looking? Urine output, MAP, SCVO2, normalization of lactates. Urine output and MAP is majorly what we need to look at. Normalization of lactate is what lactate clearance is what you need to remember. Okay, so if you remember, more than 30% is excellent, less than 10 is not good. Okay, so that is one thing you need to recall whenever you're talking about lactate clearance in patients with sepsis with septic shock. Next, we have addressed the volume of fluid. What is the type of fluid is the next question. Okay, so in the next part of your answer, write about what is the type of fluid. Okay, remember right now we have no ambiguity telling that crystalloids are the fluid of choice in patients with hypovolemia and sepsis. Okay, we all know there's a lot of evidence telling that colloids are harmful. Okay, so why again is crystalloids very much safe? No, probably overzealous over treatment with crystalloids again can cause acute kidney injury and hyperchloremia and hyperchloremic metabolic acidosis. So remember that is one of the drawbacks for balanced crystalloids. So first answer would be amount of fluid. Second type of fluid, balanced crystalloids over colloids. Again, colloids, higher mortality risk of AKI present. Crystalloids, increased crystalloids over balanced crystalloids can cause uh, risk of hyperchloremic metabolic acidosis and AKI. Just remember this. Okay. So coming to the evidence for type of fluid, what is the evidence? Your salt ed, your smart trials, your basic trials, okay, they did not come to an understanding that balanced crystalloids over zero point 0.9 saline is superior or not. Only thing what they came to a consensus was the incidence of make 30 and make 90, that is major adverse kidney events. okay, was lesser in balanced crystalloids as compared to normal saline. That is the first point and first evidence that you have to write about type of fluid. The next evidence that you guys have to mention, that starches, especially the colloids, okay, there is harmful effect based on the WISEP trial, the Scandinavian 6S trial, and the CHEST trial, okay, and that is the reason it is contraindicated. Then there will be talk about albumin, okay, so we cannot leave albumin. Majorly they will focus on this. Albios trial did not show any mortality benefit. Only thing is, even in SST guidelines, they say if there is a large volume resuscitation which is happening, okay, then you can think about using albumin. Okay, what exactly is the percentage of albumin, whether it is 20% albumin, 5% or 4.5% albumin, that needs to be discussed. Okay, so remember, balanced crystalloids is the first choice as compared to colloids in the type of fluids in sepsis management. Okay. Coming to albumin in fluid therapy, remember I told you earlier 4 to 5% albumin and 20% albumin. There is a huge difference. Okay. So there is always a problem with these fluids. What is the problem? 4 to 5% albumin is usually safe for septic shock patients, given the fact that they do not have any other issues like traumatic brain injury. Why? On the whole, if you see, 4 to 5% albumin is usually a hypo or a isooncotic fluid. Okay, so they roughly fall between 270 to 280 milliosmoles. Okay, so that is one of the reasons they say that is a hypooncotic fluid, and there will be risk of worsening the traumatic brain injury whenever we give this concentration of albumin to patients with TBI. So in any other patient, probably it is better to start with 20% albumin so that we maintain the intravascular volume, colloid oncotic pressure, and also maintain effective organ perfusion. Okay, so this is about albumin. Okay, so if at all a question is asked about mortality benefit, again, we do not see anything as of now. Okay, so that is about it. Having said that, there are a lot of trials which have been done. Okay, so there is a recent trial called as the ARIS trial, which is still awaited. ARIS trial is looking at achieving a very high target. Okay, they're trying to get at least 3 grams of albumin in the period of stay in the ICU. So probably it is an overzealous, cost effectiveness, etc., will come into picture again. So as of now, there is no mortality benefit based on a lot of trials like a SAFE trial, Albios trial, EARSS, RASP, and the meta-analysis which was given by Cochrane in 2018. Okay, so take-home point from albumin is can be used in patients requiring larger volumes, can be used in patients with non-TBI type of sepsis. If it is TBI, please do not use 4 to 5% at that particular time. Probably it's better to use 20% albumin. What is the advantage of albumin? One, it maintains the effective colloid cortic pressure, intravascular volume is maintained, and probably organ perfusion is better, making eventualities or complications like AKI reduce. Okay, this is about albumin as a fluid. Okay, so we talked about uh, volume of fluid, type of fluid. Okay, now we come about the next part of fluid therapy in sepsis, that is protocols. So earlier on, we started with 30 ml per kg. If the patient is responding well and good, probably you can do your dynamic assessment and then give this patient fluid boluses whenever it is necessary. Probably you can do your mini fluid challenge or your small boluses up to 250 or 500 ml. That depends on institution. Okay, so whenever you're giving a fluid challenge, it has to be following all the norms, and better to use dynamic indices as compared to static indices. Okay, whenever we feel that despite fluid therapy, you're unable to reach the targets of resuscitation like MAP, urine output, lactate clearance, sensorium, etc., probably at that time we need to start vasopressors. They say earlier vasopressors is better, and I will discuss why early vasopressors are better. Okay, so firstly, it will prevent fluid overload and prevent you from overzealously loading the patient with fluids. Because if we load the patient excessively with fluid, it can hamper organ perfusion. So Earlier choice of vasopressors can improve organ perfusion and it can restore the map. And when restoration of map is achieved, end organ perfusion would be better. So capillary leak, which is usually seen in the early stages of septic shock, that would also be reduced by early use of vasopressors. Ultimately, the whole thing is organ protection. Okay, so sequestration would be reduced, unnecessary overloading would be prevented, and organ protection would happen. This is the rationale for using early vasopressors in fluid therapy and sepsis. Okay, so this is actually based on a lot of trials. Remember, Banish trial. It did not focus on this, but that is what they actually found out. Okay, early initiation within 6 hours showed trend towards benefit. Okay, so this cannot be taken as the primary objective, but this was what was an observation. Okay, which they did in Vanish trial. Similar observations were made in Andromeda and Sensor trial as well. Okay, so the best way is to start it within 1 hour if it is feasible. But obviously, we are still doing our SSG guidelines up to 3 hours. Probably if your patient is a patient with chronic kidney disease, ischemic heart disease, etc., wherein you cannot give overzealous fluid therapy, probably in them you can start it within 1 hour. Other patients, especially a young patient, start with fluid resuscitation, check for volume responsiveness, and the best thing is to start inotropes less than 6 hours. Okay. By doing so, they have said that there will be decreased organ defects or multi-organ failure would be avoided and lesser length of hospitalization and requirement of fluids. Okay, so usually 0 to 3 hours fluids, 3 to 24 hours stabilize this patient, start the patient on inotropes, and 20 to 24. I mean, in the 24 hours and beyond, you might have to de-escalate the patient. So this is basically how you can go about a protocolized approach to fluid therapy in sepsis. Okay. So first line, according to SSG, NORAD is the first treatment of choice. You know, the predominant action is on the alpha 1 receptor. Okay, it also has an additional beta 1 agonist activity. Okay, second line, we have to use vasopressin. Again, it is based on the SSG guidelines. When do we start vasopressin? Usually, when we are not able to achieve a MAP target of more than 65 mm of Hg, when we are giving a NORAD of more than 0.25 to zero point 0.5 microgram per kg per minute. Okay, you have to remember this 0.25 to zero point 0.5 microgram per kg per minute. Okay, this is the cutoff for adding the second line of vasopressor, that is your vasopressin. Okay, so what is the target if you're asked? The thing is, that is your 65 mm of Hg. How did we come? That is based on two trials. One trial, if you remember, is more than good. That is your sepsis span trial. The other one is called as ovation. If you remember, is good. Otherwise, no problem. So till now, we're talking about sepsis, and in the later slides, you looked at patients not responding to fluid therapy requiring inotropes. So whenever they go into such state, as per definition, it will be converted as septic shock, right? So what do we do in patients with septic shock? In patients with septic shock, we need to think about EROS concept. Okay, so if a question is asked about what is EROS, you need to write this slide. Okay, if you take a screenshot, it's good enough. What is EROS? It is a systematic approach to management of septic shock. It involves early recognition, resuscitation, organ support, and source control. Okay. In early recognition, what do we do? We have history and clinical examination, point of care ultrasonography, appropriate imaging, and microbial testing. In resuscitation, timely initiation of fluids, inotropes, and transfusion if at all it's necessary. In organ support, you need to look for timely interventions like ventilation, renal replacement therapy, and in worst case scenario, even your extracorporeal support. In the meanwhile, when you're doing your ERO, you have to localize the source of sepsis and treat it appropriately. Whether a source control is recognized, firstly, the source is recognized and control should be optimized at the earliest. Okay, this is about ERO's concept of management of septic shock. Coming to the next part of fluid therapy or fluid management in sepsis, this is one question they've asked you previously as well. That is your ROSE concept. Okay, so what is ROSE concept? We know overzealous treatment with fluids in sepsis leads to volume overload states, and volume overload can cause fluid sequestration, back pressure related issues, and it can lead to a vicious cycle causing visceral swelling, interstitial edema, intra-abdominal hypertension, mesenteric congestion, and it just sets in a cascade of or a vicious cycle leading to multi-organ failure, and ultimately it can cause death. Okay, so to prevent this, they proposed a protocol called as the ROSE protocol. ROSE is an acronym which stands for resuscitation, optimization, stabilization, and evacuation. Okay, so what it says is in the x-axis you have the time, in the y-axis you have the cumulative balance. The resuscitative phase is usually between minutes to hours. Okay, the optimization has to be done between hours to the first 3 days. Okay, here optimization is of hemodynamics and source control both. Okay, but majorly in ROSE we are looking at hemodynamics, especially fluid therapy. Then after the 3 days up to probably a week, we have the stage of stabilization, and usually after 1 week is the stage of evacuation or de-escalation. Okay, so this is mostly what is ROSE. Okay, so remember, resuscitation is in minutes to hours, optimization hours to a 1 day, stabilization is between 3 days to a week, and after 1 week is evacuation or de-escalation. Okay, so we'll go look at ROSE in an individual format. Okay, so remember, in the initial phase, I want you to look at both the things. Okay, so look at the graph here and also look at each thing, and please stay with me when I'm discussing the graph. Okay, we should know firstly one thing. Okay, so I'll add one more slide here so that we'll discuss that together. Okay, so sepsis with septic shock, when you are talking about septic shock, it is again going to have two phases called as the ebb phase and the flow phase, similar to what we see in Burns shock. Okay, initially there will be a hypometabolic ebb phase followed by a hypermetabolic flow phase. Okay, so when I'm talking about hypometabolic, hypermetabolic, it changes. Okay, when I talk about hypometabolic, it does not mean that it is not hyperdynamic. It can be hyperdynamic. Okay, there was a confusion which one of the candidates recently asked me. Okay, so even I had to look in much deeper. So remember, take home points: any shock will have two types of phases. One is, the first phase is the ebb phase, it follows the flow phase. Ebb phase hypometabolic, flow phase hypermetabolic. Okay, so in ROSE concept, in R stands for resuscitation. Here we have to be very free in giving fluids. Okay, so what they tell is early adequate fluid management, that is what is EAFM. Okay, so in early adequate fluid management, what is the volume of fluid that we give? That is roughly around 30 ml per kg per hour. Okay, after giving this, you can still continue boluses of 4 ml per kg, which can be given at 5 to 10 minute interval to reach a target of more than 65 mm of Hg. So what do we do this? Based on what? The triggers for giving fluids would be a positive, PPV, PLR test being positive, lactates getting elevated, your IVC collapsibility index being more than 50%, so on and so forth. So there are triggers that we need to look into along with your MAP target, and then you have to start early adequate fluid management in R, that is your resuscitative phase of shock. Okay, once this has happened, then we go into stage of optimization. So I told you this is minutes, then we come into hours. Okay, that is your O, or your optimization phase, which focuses mainly on maintenance fluids. Okay, majorly we have to avoid fluid creep like we saw in Burns as well. Okay, so the aim is to achieve a neutral balance between the day 1 and day 3. Okay, so here what do we have to see? Again, you have to make sure that the MAP target is normalized, PLR is always negative, lactate is always maintained less than 2. Okay, so whenever there is some amount of volume overload which is happening, we need to de-resuscitate at that particular time. Okay, or else you have to maintain the fluid. Okay, so that is why here you can see, here it's escalation, here it is de-escalation also. De-escalation is different as compared to de-resuscitation. Okay, so in resuscitation, you be bindas. You can give 30 ml per kg per hour. After that, do a fluid challenge, give 4 ml per kg every 5 to 10 minutes based on your test of fluid responsiveness. In optimization phase, you need to think about all of this. Okay, that is, you need to think about maintenance, keeping these targets at the optimal level. Coming to the next stage, that is your stabilization phase. Usually in optimization and stabilization, you see this LCFM. Okay, what does LCFM stands for? It is late conservative fluid management. Okay, so in late conservative fluid management, majorly what we are looking at is we do not want to give excessive fluid, okay, because there is always a risk of ischemia reperfusion injury which it can happen at this particular time. Okay, so this is what is written here. Okay, that is your second hit. There are four hits. Okay, whenever you have this graph is a little complicated, so I have to explain each thing. Okay, just keep a watch on that. Okay, so in this phase, when we are talking about late conservative fluid management, we are conservative in giving fluids because we do not want any ischemia reperfusion injury from happening. Okay, that is the main focus of optimization and stabilization phase. Having said that, we also have to keep a close watch on the targets. Okay, so always you just can remember MAP, lactate, IVC. Okay, along with this, if you can remember PPV and SVV, it is good enough. Okay, so the only thing is if you can write this throughout, probably that is good enough. Okay, in this especially stabilization and evacuation phase, you can talk about your Vexus score also. Okay, so in this when you're talking about the evacuation phase, you can tell that high vexus initiates the phase of evacuation, wherein you will start removing excessive fluid if at all it is present. So, in evacuation phase, okay, so what we usually do is late goal directed fluid removal. Okay, so that is what is written as LGFR here. Okay, usually it starts between days to weeks, so roughly it is after 4 to 5 days itself you can start de-resuscitating the patient. Okay, so this is about ROSE. Okay, so you see something called as SAVE, right? SAVE is nothing but an acronym for uh, sepsis guided volume evacuation. Okay, sepsis assessment and volume evacuation. Okay, so if at all we remove excessive fluids, then it also causes problems. Okay, so that again can cause the fourth hit, that can cause risk of hypoperfusion. Okay, so remember, in individual terms, I'll just revise this part. Okay, so x-axis, y-axis. X-axis is time, y-axis is volume status. Initially, in resuscitation, B bindas, you can give 30 ml per kg, followed by 4 ml per kg every 5 to 10 minutes. Early adequate fluid management. Optimization phase, you have to maintain the trigger targets. Okay, so there should not be any fluid responsiveness that is seen. Okay, I mean, there should be optimization of fluid targets. Okay, so your PRR should be negative and lactate should be normal in optimization. Next, we have stabilization, wherein we have late conservative fluid management. And finally, we have evacuation, that is late goal directed fluid removal. Okay, so these are the four parts of ROSE. Okay, so remember, R is between minutes to hours. Okay, O is between hours to days. S is days to weeks. Okay, and E is after 1 week. Okay, so we need to get all of this within 1 week of hospitalization. Okay, so if at all these are not done properly, then there can be a lot of detrimental effects which can happen in the initial phase. That is the initial hit. If you don't treat properly, you see this image and this image, you'll understand it together. Okay, you have to understand it as a whole. So the first image shows what you do for resuscitation, and if you don't do properly, what will happen. So if the patient comes to you at time 0, if you treat the patient properly, then the risk of organ failure comes down. Okay, so you are treating the initial insult. If you treat overzealously this patient, again, then also there is a risk of organ failure developing. That is what is the upstroke which you see in organ failure in the graph below. Okay, so that is why I was talking to you about de-escalation, that is late conservative fluid management. So once you start seeing there is some amount of uh, venous overload or vascular overload which is coming there, you have to start de-resuscitating the patient. Once you start achieving the de-resuscitation, again you start seeing that organ failure starts coming down. Okay, so that will be your third hit. So if the third hit will happen when you overzealously continue treating the patient. So first, without treating, you will have organ failure. Starting treating, because it's returning to normalcy, there might be ischemia reperfusion injury or global increased permeability syndrome. Okay, global increased permeability syndrome is because still there are some leaky capillaries present, and that is one thing which can cause damage to the organs. Later on, you have the last phase. Okay, the last phase, again, if you see here, again you're seeing an upstroke towards organ failure. Why is that present? It is majorly present because if you still continue evacuation phase, that is continue the patient on de-resuscitation strategy like starving the patient of not giving fluids or giving excessive diuretic therapy or renal replacement therapy, the patient can still again develop organ failure. Okay, so this is the four hit rose concept as a whole. Okay, so it does not end with resuscitation, optimization, stabilization, evacuation alone. You need to understand the hits also and talk about organ failure and parts of fluid management. Hope I'm clear. Okay. I know it's a little complicated. If you feel that that previous thing was very complicated, you cannot remember much, just remember this slide. Okay, that is why I put this slide. So remember, in resuscitation phase, you can do early adequate fluid management with 30 ml per kg, followed by small boluses of 4 ml per kg. If you're not reaching the target, start early noradrenaline, especially when the diastolic BP is less than 50 mm of Hg or a diastolic shock index of more than 3. In optimization phase, you have to again consider about conservative fluid management. Okay, check for fluid balances. If at all fluid is necessary, it should be as boluses. At this time, if you feel there's increased requirement of crystalloids, you can use fluids like albumin. In stabilization phase, again watch for fluid creep because this patient is at an increased risk of developing global increased permeability syndrome or leak syndrome. Okay, so in these patients, you have to start de-resuscitation or evacuation and then keep a check on cumulative fluid balance. It can either be with diuretics, ultrafiltration, or with the need of albumin. Okay, but only thing is maintain euvolemia in this patient. Don't again dehydrate the patient. Okay, so this is about rose concept. Okay. So now we have come to an understanding of Eros, Rose concept in fluid therapy. Then the last thing is what about liberal versus conservative fluids. Okay, so Rose, we were all talking about early liberal or early adequate fluid management, followed by late conservative fluid management. Has there been any major mortality benefit between the two? Unlikely. Okay, so there are a lot of studies which were done. Okay, starting from the EGDT, Feast, Arise, SSP, the latest one being the Clovers trial in 2023. Okay, currently there is no consensus telling that restrictive group is better or superior over liberal fluid resuscitation group. But having said that, it is always better to do a dynamic fluid assessment and maintain euvolemia as much as possible. So why do we have to do this? Why do we have to maintain euvolemia, avoid overzealous fluid resuscitation? That is because there are adverse effects of fluid overload. What are they? Tissue edema, pulmonary complications, cardiovascular effects, renal impact, coagulation defects, and gastrointestinal hepatic and cerebral edema also. So these are the effects or complications of overzealous fluid therapy. Okay, if they ask you fluid therapy in general also, you need to write about complications of fluid therapy. In this, you can write it as an individual organ based approach. Okay, so remember, in tissue edema, it causes impaired oxygen dissociation, pulmonary complications like pulmonary edema, worst case scenario ARDS, Cardiovascular definitely puts a strain on the heart. Okay, your right ventricular strain can increase. It hampers the demand supply mismatch. Okay, similarly, dilutional coagulopathy can happen, hypothermia can worsen. All of this is the issue with the coagulation factors. Venous back pressure can cause acute kidney injury again. Okay, your renal resistive index, etc., comes into picture, especially when you're using tools like Vexis. Okay, Vexis, RRI, all of them can be used as a tool to look for the development of acute kidney injury in patients with overzealous fluid management. Okay, so this is about complications of fluid overload. So to avoid complications of fluid overload, you have to use fluid stewardship. Okay, so fluid stewardship is similar to your drug stewardship. What I told you earlier, fluid is again a drug. Okay, treat it with the four Ds. Okay, that is your drug. What are we using? What is the type of crystalloid? If you're using a colloid, for which patient we are using and when are we using? All of that has to be questioned. How much we are using, that is the dose. How long are we using? Is the patient is in resuscitative phase, optimization phase, stabilization phase, or the evacuation phase? So all of this comes into questioning. And finally, whenever we have achieved our targets, we need to think about de-escalation. Okay, if you can take this screenshot, I think so you'll understand it as a whole. Okay, here this fluid stewardship, when you're looking at it, it looks into Rowe's concept as well. If you see, okay, there are four questions, there are four indications, and four stages and four hits. They are also mentioned here. If you can read this slide, I think so you'll be able to understand. Remember, Rowe's concept was actually given by Manu Malbrain. Okay, so it was him who started it in, I think so, 2014 and later on. Okay, just remember this. So if at all the question is asked, to summarize, starts with initial resuscitation, balanced crystalloids over colloids. Dynamic measures should be taken. Early vasopressors therapy, Vanish trial, sensor trial, Andromeda shock trial. Okay, that is the thing. De-resuscitation based on the Rose concept. Albumin only role is whenever there's excessive fluid which is required. Okay, always keep a watch, because if you don't keep a watch, the patient can end up having fluid overload state. That is your fluid accumulation syndrome or global increased permeability syndrome. Okay, so this is a gist of what happens if excessive overzealous fluid therapy is done. Okay, so it can cause or cerebral edema, pulmonary edema, ARDS, liver congestion, acute kidney injury, myocardial ischemia, gut congestion, etc. Okay, so this is about fluid therapy. So treat it as a drug. Okay, that is the most important take home point. Thank you. So I know it was quite an extensive talk, but what I want you to remember here is, first, write about the aim, okay? Then talk about the pathophysiology and the goals. Then assessment, you can write this, okay? History, examination, and lab test, and what are the targets. Initially, if you resuscitate, if the patient gets these targets, you can stop the fluids. If it is inadequate, probably you might have to start vasopressors. Okay. Again, write one a small para on type of fluid. Okay, and what is the choice and what are the trials? Again, albumin, no major benefit as of now in terms of mortality. Probably it reduces the risk of AKI. Okay, protocolized approach is what you want. Early vasopressor therapy. When you are talking about protocolized therapy, you can talk about the Rose concept. Okay, remember Rose, four hits, four stages: early adequate fluid management, late conservative, late goal directed fluid removal, and then volume evacuation. Okay, so this is what you need to remember. Four hits. Remember, organ damage can happen in all the stages. It just depends on how we are resuscitating. Okay, so this is about the Rose concept. No major evidence based on liberal versus conservative. Fluid overload. When you're talking about fluid therapy, don't forget to write the complications of fluid overload. Then talk about fluid stewardship. If the question itself is fluid stewardship, probably if you write this slide, it's more than enough. Okay. So, what are the worst case complications? They might ask you questions like, what is global increased permeability syndrome or fluid accumulation syndrome? Okay. So, it's just by overzealous treatment in stage 3 of Rose concept, that is your stabilization phase. Okay, because if you have continued overzealously treating the patient can end up in something called as GIPS. Okay, So this is about fluid therapy.